the three different programs that we're going to cover today. So again, welcome to all of those who are just joining us. Part 2 will cover Rmed, Erg Med, and Gmed in today's session. Next slide, please. Well, as you probably heard walking virtually into this webinar, it's being recorded. So we have all of our participants on mute, and that will be the case for the duration of the webinar. Now, try to avoid that chat feature. This is a wonderful webinar through Zoom, and they have their own Q&A section. So you should see at the bottom of your screen, Q&A. That's a function at the bottom of your screen. If you think of a question while the person is talking about their program, go ahead and enter it. We are going to hold all questions until the end, where we can have all of our panelists come back onto the stage. And as I mentioned, if you're just joining us, this is part 2 of our 2-part series for scholarly concentrations. And part 1 is already on our YouTube channel, so we'll be sure to send both of them out at the end. And it usually takes about 2 or 3 days to upload all of that to YouTube. I'm going to turn it over to Dr. Miri, who's going to walk us through quickly what are scholarly concentration programs and how you can apply.
Thank you so much, Bridget. Good evening, everyone, and welcome. So excited to host you here tonight. I'm just going to give you a little bit of logistics about our scholarly concentration programs. So the programs are available to all of our applicants every application cycle. Now, we do have some site restrictions on the different programs, but that does not impede your ability to apply to the programs. These programs are optional for all of the students who are applying to us, and it is a selective process. So our capacity is about 1/3 of all of the students that we admit annually to the College of Medicine, which is 300. You are able to combine the scholarly concentration program with any of our master's or doctoral joint degrees, and we see a lot of compatibility and alignment between the SCPs and particularly our master's in public health. You can apply to as many of them as you want, but you have to get your heart set on one and select one to pursue formally and officially. Now, you'll meet our program directors tonight, and you will see that they are all very generous with their time and very supportive of students. And so you will have opportunities to engage with them, have a project that's informed by maybe some of the other programs, but you will have to select one to pursue officially. Application process, we've made it so easy for you. You basically apply to the scholarly concentration programs through our secondary application portal. And it has a later deadline than our secondary. So you might know that our secondary application deadline is December 1st, but you have all the way up through March 1st to apply for the scholarly concentration programs. Admissions to the programs varies in terms of their timing, and so you will hear from our program directors, but generally the applications need to be submitted, and there will be another interview for you for consideration for admission into the program. So tonight, as Bridget has already shared with you, we will feature 3 of our programs. Global Medicine, which is a program that trains students to be global health leaders with an emphasis on addressing global health equity. Students will gain skill and knowledge to develop careers as global citizens, clinicians, educators, policymakers, or researchers. You will also hear from our Erg Med program located on the Peoria campus. Erg Med offers medical students the opportunity to learn how to apply the tools and techniques of innovation to advance health equity in all under-resourced environments, including rural, urban, and global. And you will also hear from our rural medicine program. Rural medicine is located on our Rockford campus, and our Rmed program has a curriculum that focuses on developing the interprofessional knowledge, skills, and attitudes required of rural health professions. So without any further ado, I will hand this over to Dr. Fess to introduce you to Rmed.
Hello and welcome. I am Dr. Kara Fess. I am the Rmed Program Director in Rockford, Illinois with the University of Illinois College of Medicine. Just a little bit about myself. I'm a graduate myself from the Rmed Program. I graduated in 1999. I did family medicine residency at the University of Texas in San Antonio, and then returned to Illinois to practice in a rural health clinic in LaSalle, Illinois. And I started last fall as Rmed Program Director. So why Rmed? Why consider rural medical education? The reality of rural living is that 17% of the population in the United States live in rural areas, but less than 10% of all doctors practice rural medicine. So it's predicted that we're going to be facing a major shortage of physicians in rural America in the next few years. There's currently about 500 rural physician positions open in Illinois alone, and about 500 rural doctors in Illinois are approaching retirement age. So the shortage is a critical problem, and Rmed is here to try to help meet those needs. In rural Illinois, of the 102 counties, 83 are designated rural by the IDPH. 81 of those 83 counties are underserved. Illinois ranks 8th in the nation for the number of residents living in health profession shortage areas. And the rural areas are desperately trying to recruit primary care physicians. It's going to be, as I mentioned, a challenge to keep up with physicians who are approaching retirement age. So is there an answer to the physician shortage problem in rural America? We think so. Rmed is here to try to help meet the needs of this projected rural healthcare shortage. So the mission of the Rmed program is to seek and admit students to prepare them who come from rural areas, and upon completion of their residency training will locate and practice in a rural location as a rural physician. So we follow a grow your own model type format. We recruit students with rural backgrounds to return hopefully to rural communities to meet these needs. Our graduates of the program help and serve as preceptors for our students. And basically the Rmed program is an add-on curriculum. We start in year 1 with exposure to rural medicine in addition to the traditional medical school curriculum. So some history about the Rmed program. It was established in 1992. As years ago, we recognized this need for future rural medicine physicians. So it began with the initial class in 1993. And then it evolved. We developed the National Center for Rural Health Professions in 2003. And this incorporates other professions, including rural pharmacy. That program was established in 2010. In 2014, we expanded outside the state of Illinois to rural tribal preceptorships with the Karuk tribe in Northern California and in rural Wyoming on the Wind River Reservation, which houses both the Arapaho and Shoshone tribes. So total graduates from inception of the program, we're up to 389. 75% of our graduates practice in the state of Illinois, and 88% of those are practicing primary care. So out of state, we also are very successful with primary care physicians meeting the needs of other rural communities. 71% of our graduates who moved out of state are involved in primary care. So again, our success, which we're very proud of, 83% of our graduates are practicing in towns with population of less than 75,000 people. And you can see the breakdown of those communities of where our graduates go. So a little bit more about our curriculum. We have an interprofessional curriculum. We work with pharmacy students, nursing students, and social work students. And we have sessions in the evenings in which our students work together through different seminars and have different experiences. Our faculty also include different professions, including pharmacists, nurse practitioners, MDs, social workers, physical therapists. So we truly follow a very interprofessional curriculum. In the first and second years, we focus on these seminars and site visits, some of which are titled things like No Harm on the Farm, where we go out to a rural location and tour a farm and talk about what hazards there exist on that farm. We go to different parts of the state of Illinois. One trip is called Southern Exposure, where we take the students to different health systems and clinics in the southern part of the state to learn about what it's like to practice medicine in that area. And then there's lectures again with the pharmacy and nursing students, social work students, and dietetic students. And then we also have some shadowing experiences the first and second year. They shadow their own profession as well as someone in a different profession. The curriculum in the third year is, again, ongoing evening seminars. We touch on the concepts of community-based medicine. We start working on a community-oriented primary care project, or COPC project. They will work with a faculty advisor throughout different stages of this project. The initial stages involve performing a community health needs assessment of their target community to determine what would be applicable to research in that area. What type of impact can the student make while they're later during their fourth year. They also have the opportunity to do third year clerkships in rural communities in family medicine, pediatrics, psych, general surgery, OB-GYN, and they can spend time there during their third year doing those clinicals. The fourth year rotations, our kind of capstone project during the fourth year is a 16-week rural family medicine preceptorship. During this experience, the RMed student will work with a preceptor one-on-one for the duration of the 16 weeks. They'll get a better experience what clinical medicine is like in a rural setting. They'll understand the rural healthcare systems. They'll become more immersed in the community and see how it is to live in a rural area. And then they will address the community health need through the COPC process to make an impact as much as possible during the time there. Some of these projects have had lasting impacts on the community and have been continued once the student has left that area. So currently we have over 50 clinical sites throughout the state of Illinois in which students can participate during their third or fourth years. We also have the Native American rural sites in both California and Wyoming. So again, who is best suited to care for rural populations? Well, we think that it's those who come from and understand the rural way of life. That's called rurality. What are the benefits of participating in the RMed curriculum and program? Well, it's a rural curriculum. It starts in the first year and goes throughout all 4 years of medical school. There's classmates who are also from similar backgrounds. There's an interdisciplinary, interprofessional training aspect to the program, collaboration with nursing students, pharmacy students, social work students, and dietetic students from other campuses. There's the rural residency development. And then there's the individualized attention that comes from being in a smaller program. So Rmed opportunities. Rmed has a replicated program in Thailand at the Princess Medical School. There's the international rotations for research in Scotland and Sweden. We've developed the Native American pathway in Wyoming and California. We work with the 4-H through a health jam session, which is conducted locally in the schools. And then there's high school healthcare camps. Our students participate as camp advisors to these high school students over the summer month. And then there's the interdisciplinary preceptorships. We also are a collaborating center with WHO and the Pan American Health Organization. If there's further questions, we do have an Rmed recruiter. He is out visiting different schools. His name is Mark Maurer. He's a great resource and available by phone or email if there's any questions regarding the program or admissions process. We also have our Facebook page and our website. And I have a student who is available with us this evening. I have Lincoln, who is going to help give some student perspective.
All right. Hey, everybody, and thank you, Dr. Fess. So just for everyone else, my name's Lincoln Johnson. I'm a third year in the program, and I'm actually coming to Rmed long distance away from a rural village in Alaska, but I did college in Southern Illinois and actually worked closely with an Rmed grad as a scribe. And so he was kind of the first one who put me onto the idea of the kind of a different form of training in which you specifically emphasize rural medicine. You know, I grew up in a spot that didn't have a doctor. You know, the closest one was an hour away. And so that really led to my community just not getting medical treatment. And so I saw that as a need. And especially even then when I went to college in Southern Illinois, again, small town, there was a need for doctors and just the cry out from the community of not being able to get quality treatment. And so applying into Rmed, it was great. Even from the very first day of the interview session, the family-like atmosphere that I felt was unlike any other one of my interviews I'd gone to. And when it actually came down to deciding, that was the deciding factor of where I went to medical school, was based on kind of the camaraderie I felt just in meeting my classmates and meeting the faculty to go to this Rmed program. And I'd say throughout the training, not that I don't have great relationships with students in our class that are, you know, in the general medicine curriculum, but all of my closest ties are to those that are also in the Rmed program, just from that shared understanding of what it's like growing up in a rural environment and seeing some of those things. And, you know, I'd say throughout the first 2 years, you really get a kind of a better appreciation, not only of your own specialty, but also from that interdisciplinary action. We work with like the nurse practitioner students and some of these other modalities. Working with them, you get to take on kind of a different approach, and you see things from their perspective that as MD aren't necessarily on the forefront of your mind. And so learning how to know how to work with those different teams can help develop better care for the patients all around. And now that I'm in my third year and I'm starting these rural rotations for my clerkships, I'm actually just coming off of my surgery rotation, in which I spent 3 weeks of it in a rural spot with an Rmed grad. And I got to do more in those 3 weeks with her than I did over the next 5 weeks when I was in Rockford. Not that I didn't have a great experience there, but just having that individualized one-on-one attention. It's a very intense learning style, and you get to do a lot and you feel a lot more confident in it. And I'm really looking forward to my 4th year rotation when I do get to do 4 months, because I know at that same time, I'm going to get a great experience and I'm going to get a better appreciation of what it's going to be like as being a doctor in a rural town.
Thank you, Lincoln. I appreciate all you've said. That's really all I think I have to say as well. So I will turn it back over to Bridget. Thank you.
Thank you so much. We enjoyed hearing from the both of you about the Rmed program. Next, we're going to be turning it over to Nicole Robertson, who is going to talk to us about Erg Med.
Hello, everyone. Can you hear me okay? Great. Well, thanks for joining us today. I'm Nicole Robertson. I'm the Associate Program Director of the Erg Med Program, which is the Innovation in Rural Global Medicine. And I'm going to go ahead and share my screen. Our director of our program, Bridget, have you been able to see Dr. Stewart de Ramirez? She was on for just a second, and then I think I lost her for a minute. Have you seen her?
I'm still here, Nicole.
Oh, good. You're still here. Okay. I didn't
Yeah,
see
it just says that the host won't let me show myself with the video, but nobody gets to see my face. I can just speak to the slides.
Okay. Okay, so let me just get started here, and we'll turn the slideshow on. Okay, so yes, Dr. Sarah Stewart de Ramirez is joining us as well. We are going to co-present today. She's going to do the first half, and then we'll turn it over to me. So I will go ahead and mute myself right now and go let you take over.
Great. Thanks for your time today. I just wanted to give an overview of our program that is now 5 years old, with our first group of graduates having graduated last year, called Innovation in Rural Global Medicine. And just to tie it, because many students ask, if they're interested in health inequities in rural spaces, et cetera, can you do both RSPP and Erg Med, in case that wasn't covered? We do have many students on our campus that combine both Erg Med with the clinical experiences of RSPP in their third year. So they do both. So that is an option. Before we get started, I think it's always something that students ask is a little bit about my background. Since I created the track 5 years ago, just to understand the lens in which it was formed, because it's unique to the Peoria campus at this time. So I grew up in rural Illinois and started working in the country of Haiti at the age of 13. And so most of my background really has been in global health, but with the understanding that growing up in rural Illinois, I very much understood the health disparities that exist in terms of access barriers just between rural and urban. And so throughout my course of education, I lived in Africa for a couple of years working on HIV/AIDS, really at the time when the epidemic was exploding in sub-Saharan Africa, and there was really hard clinical access to any essential meds for HIV. I studied in London then after that, both health economics and public health in developing countries, really in an effort to understand those larger forces which create poverty and ill health for some of our most vulnerable patients. And then came back at that time and worked under Paul Farmer, which some of you know has done a lot of work on access to care and inequities in health outcomes at a global level during medical school. And so I was at medical school at Harvard for 4 years, and during that time worked with the Bill and Melinda Gates Foundation, really in sub-Saharan Africa, getting access to care and access to clinical trials for the evolving HPV vaccine at the time. And I think at that point was when it was really impressed upon me that as we started to work in that fusion of population health or public health and medicine, that really what was needed was new solutions, or these leap over technologies, so that when we worked with a population that was most vulnerable, they weren't required to progress through all the stages of health systems development, but rather that we could create new and different solutions altogether. And I trained then as an emergency medicine physician at Hopkins and was there for 10 years, continued to work in that space of innovation and health inequities, and then moved home back here to Peoria and started this track. So this track is really about the fusion of those concepts of health inequities and the ability to create new tools, technologies, and interventions to solve for them. So next slide. So just to bring you back to what is grounded and what we were just talking a little bit about is that whether we're talking about rural and urban, whether we're talking about sub-Saharan Africa versus the US, or whether you're here in Chicago and talking about Northern Chicago versus Southern Chicago, what is at the root of all of this is something that we've been talking a lot about the last year or so. Is the simple fact that health status is really determined by where you live. It's quite profound, even by miles within a city, that your address very much determines your life expectancy. And so the question is why that is. And so next slide, Nicole. And so that's really rooted in this concept of social determinants of health, which is something our track really focuses on and teaches around how to analyze those health disparities. You can read really the WHO's first definition on that, but just this concept that these upstream determinants of health really manifest as the downstream health disparities and health inequities that we witness with our patients on a daily basis. Next slide. And so we see that a lot in our state, which is why this track is very well positioned to start here in Peoria. Sorry, there's lots of chats, so I'm trying to read them at the same time. And you can tell here, if you look at the rural-urban disparities, that we know that our rural patients tend to be older, have less access to healthcare, less access to prescription drugs, and that, you know, by and large, whether you're looking at older age groups or younger age groups, at pretty much every age group, the death rates, mortality rates, and impact on morbidity is higher in our rural areas than in our urban areas. Next slide. And I think part of the difficulty there is there's a really big mismatch between where our physicians end up. As you know, the Rmed program can very much substantiate here that the need is very great in rural areas, but you know, a very small percentage, less than 10% of our physicians ultimately settled there. And so that's one example of this supply-demand mismatch that's creating these health disparities. Next slide. And that's not unlike a lot of what we see globally. We've certainly seen it through the COVID pandemic, access to vaccinations, access to treatment, PPE, all of the different things that we've seen kind of culminate. Things that are simple, like a child dying every 5 minutes from dehydration, things as simple as that in Haiti, or the fact that there are only 3 pediatricians in the country of Malawi. And so we know that these health inequities and the way that we measure them is very important and is geographically rooted as an opportunity, again, for intervention and innovation. Next slide. And this is a slide that really, a quote that really hit me in the early 2000s, and I was really on one side of it. The prudence of investing billions in the development of new technologies while investing only a fraction of that amount in the correction of disparities deserves reconsideration. It's an imbalance that may claim more lives than it's saved. Really saying that we shouldn't focus on innovation, we should just focus on disparities. But over time, you know, as you'll see here, I believe that we've learned more and more about how to really analyze those disparities, really analyze those health inequities. And now we see that, in fact, those two worlds can come together. Next slide. This is really rooted, I think, this fact in the concept that in American healthcare, until really this last year, we've seen research and innovation be very much focused within a medicalized approach, where the key is access, getting everyone access to that great reactive medical care. And the concept that public health has really been a preventive focus. They haven't been in any way converged together historically. They're two very separate systems. And you know, I think from the public health side, when there you see a disparity, you think it's about education and prevention. And the medicalized approach really thinks it's more of one of access. And so as we've seen over the last year, when you're talking about, in particular, infectious diseases, you see the need to converge, and you see the strength of convergence even in the management of chronic diseases. And so that's what we really try to do in Erg Med, is bring together the concept of disparities analysis from a population health standpoint with a medical lens, and look there to ask the question around the creation of new solutions, tools, technologies, and interventions. And so in bringing together these two constructs, you know, usually to think outside of the box, you have to be able to think of things differently. And we believe within Erg Med that if we continue to do things the same old way, that we'll, you know, continue to get those same old results. And so to think differently, we have to bring this unique concept of bringing together the context of population health, and the medical system, medicalized approach in the context of innovation around healthcare disparities. And so that's what this class is really about. And I think this is the quote that I always end with, because, you know, as we work in some of our poorest, most vulnerable populations, folks often ask me, like, but what's the role of digital health and all these fancy innovations when we have real health disparities? Is that the space we should be working? And I always say that's exactly the space that we should be working, because to think about the concept that science and innovation should only be accessed by the folks that have great access to healthcare already, that the fruits of those labors be put there, we know means that will only exacerbate the health inequities that exist. So if we're able to kind of turn the tides of discovery and partner with our communities in co-development, we can really harness, I think, the fruits of innovation for the reduction of inequities and the promotion of human flourishing. And so that's really the basis for this course. So Nicole's going to spend the last few minutes here just giving you the nuts and the bolts of this 4-year course. And I want to thank you for your time.
Great. Thank you so much, Dr. De Ramirez. I will give an overview and a history, and then I'll go into a little bit more, again, as she said, a little bit of the nuts and bolts of how this program works and what that would look like for you as future students. The class of 2021 was our first cohort of students to achieve full credit upon graduation. So congratulations to our first cohort. They have gone on to their specialties, their residency programs. I'll have a chance to talk a little bit about that later. But Erg Med and their experience as Erg Med students throughout medical school played a pretty significant role during their residency application process. We currently have 39 students enrolled over 4 years, and we're just about to interview our incoming cohort for the class of 2025, where we will welcome an additional 12 students into the Erg Med program. We do have a formal academic partnership with Mbarara University of Science and Technology that's in Mbarara, Uganda, that you will see in a few minutes of what our experience in our immersive rotation looks like with our academic partners. We also work with a local rural hospital system, OSF Healthcare, that's in Streator, Illinois, that's about an hour away from Peoria. And we are also working, pandemic dependent, we are working on expanding our global and our local partnerships to really offer students a menu of opportunities to really have that immersive experience. Overall, the goals, as Dr. De Ramirez mentioned, we really want students to graduate and develop a thorough understanding of those barriers to healthcare, whether they are in an urban, a rural, or a global environment, to really understand that under-resourced and marginalized communities, regardless of geographic location, the challenges that they are facing. We want to provide you an opportunity to learn about a variety of healthcare delivery models in austere or low-resource settings, and we do so by collaborating with multiple partners in multiple locations. And then basically we want you to develop that competency to really use those tools and techniques of innovation to apply them to reducing health disparities. Overall, we want to give you the tools and the techniques to be champions of health equity innovation in your residency and in your future careers. Overall, this gives you an idea. This is a 4-year longitudinal program. This shows you how we have it mapped out. During your first year of medical school, you will participate in med colloquia sessions, some seminars, and we do have online modules in the areas of rural, global, rural health, global health, and innovation. Those are more self-directed work. So between your first and second year, that is what you would focus on. It's really independent study with some guidance and mentorship from our faculty leadership. At the end of your second year, we have some touch bases. You'll see just a couple of 2-page reflection. We just want to make sure that you're on track. We have those milestones to keep you progressing through the curriculum. In your third year, there is a 2-week pre-departure course or a global rural health simulation course that precedes an austere immersive experience. And that is where you actually go spend 2 weeks in one of the environments that we've talked about in either a local rural, global rural, or an urban environment. And then after you return from that experience, that's when we begin your capstone project. And that develops throughout the end of your third year into your fourth year with a final capstone project and presentation. So again, just breaking it down, you have some opportunities for seminars with multidisciplinary experts. We bring in engineers, we have data analytics teams that we work with, we have experts in population health, in ventures and partnerships to really talk about that innovation and business development piece. So it's a variety of a broad spectrum of experts that we will bring in to share their expertise with you. And then we have med colloquia sessions and then the online lectures and the modules and a community service component that just allows you to really get to know Peoria, get to know the location that you will be in for 4 years. During that second year, like we talked about, there's the Global Rural Health Simulation course that is 2 weeks, and then an Osteo Rotation that is faculty precepted. And again, you have an option of participating in a global rotation, a rural, or at an urban partner site. I wanted to highlight for just a couple of slides here, those 4 weeks in your third year. That's really the highlight of our program. We provide you with the building blocks to really give you the information and the foundation of how you advance health equity using the tools of innovation. But it's really during these 2 weeks of the Global Rural Health Simulation course where we cover a variety of topics. We talk about cultural humility and sustainable development. We do some simulation education, global travel medicine and urban health, where we bring in a variety of experts to speak with you during those 2 weeks before you are immersed in that environment. And then for those 2 weeks of the Osteo Rotation, the first week, and these pictures on the left here are actually from our trip in February of 2020, where we participated and traveled to Mbarara, Uganda to work with our partners at the Mbarara University of Science and Technology. We have some of our med students here, but as you can see, the majority of the time spent during your first week is really field interviews. You're talking to people, you're conducting interviews, you're doing observations. We travel to rural health centers and regional referral hospitals. You have an opportunity to meet with clinicians, with health workers, with village health team members to really understand and define the problem statement that you will be assigned prior to departure. So that you can really get a good sense of understanding what the problem is as it exists in that community. So what we ask you to do at the end of that first week is that you really have an opportunity to identify the gap. What's the problem? How do you define it? And then you move on to developing your hook is where is the innovation piece, that if you were to design an innovative solution, what might that look like to solve the health challenge that you've been assigned? So the second week of the rotation, we switch gears and move into much more of kind of that creative, innovative space where you come up with a very high level concept idea. You have an opportunity to pitch it to a panel of experts, as you can see in the bottom left picture there. Our students presented their idea, Shark Tank style, and received feedback from the panel of expert judges to really say if this is an opportunity for innovation and for advancement. They provide you all of that feedback and recommendations as to how to further develop that concept. And then in the final year, your capstone project is really a chance to demonstrate not only the innovation and the concept that you've come up with, but how you've evolved as learners and innovators over these 4 years of your medical career, as well as identify those relevant skills and knowledge gained and discuss how they can be used in your future career. What tools will you take away from this experience at the end of your 4 years, in addition to the innovative concept that you have created? So I just wanted to share a couple of frequently asked questions that we get about this program. Is there an extra student expense for global travel? There is not. We actually have an endowment that supports the travel component of our program, which is why we have to limit it to 12 students per year. What specialties do most students who graduate from Erg Med go into? You know, it's really, it's a variety. We, the graduating class of 2021, we had students that went into OBGYN, we had urology, family medicine, sports medicine. We had quite a variety. So there, it is not limited to any one particular specialty. And then the last question that we receive pretty frequently is whether there's any certain undergraduate degrees that are preferred. And again, there is not. There are no prerequisites to apply for our program. We have a pretty broad spectrum of students with varying degrees, from graphic design to biomedical engineering. So there's no specific undergraduate degree that you would need to apply to our program. So with that, I have my name and my email up on the screen here. Feel free to reach out to me with any questions that you might have. And there is also a link there to our website. If you go to peoria.medicine.uic.edu and look for Erg Med, you will be able to get more information about our program. So with that, we do have a student who is with us now. I will mute myself, and Saad, if you would like to turn your camera on and you can join us. I just wanted to see if I could get an idea from you of, as an M4, can you tell us so far what your experience has been? Speak to us a little bit about kind of the building blocks of your first and second year and how they really helped you in your third year Osteo Rotation.
Hi everyone, my name is Saad. I'm a fourth year at Peoria campus, part of the Erg Med program. Before I do that, Nicole, just a brief overview of like why I chose Erg Med and why Erg Med has really been interesting to me. Coming from undergrad, I've always been interested in sort of innovation and how do we use technology and how do we use different methods of thinking to help patients at the end of the day, right? Because there's a lot of physicians, there's a lot of innovations going on, but I never necessarily saw the two connect as much. And my goal was how can we combine this together? And so coming from like a sort of, and then I on a second look day, Dr. Ramirez, she gave this talk, and I was really interested in how we can use innovation to help inequities, sort of using this inequities portion of it. And so that's kind of what drew me to Erg Med, is sort of is to help inequities, but looking at it through sort of an innovation lens. It's not necessarily technology, but more so how do we use a different way of thinking to help patients at the end of the day, especially those that are underserved the most. So social determinants of health play a big role in this, and so that's something that I learned primarily through my first year during that sort of building blocks. As you mentioned in your talk, the building blocks, you have medical colloquia, which are built into the phase 1 curriculum, even if you are part of a concentration or if you're not. And so part of that, you have these sort of 3-hour talks by different people that come in to the school and talk to us about sort of, what it's like being a CEO of a rural hospital and sort of shortages they face, for example, as with like not having OB care, and what sort of what things they have to do in terms of that, sort of the challenges they face in getting their patients proper access to care. We had like jump engineers come talk to us about like cost-effective brachytherapy models and how do we have like these engineers working on cost-effective models to train brachytherapy experts and help patients with like a radiation therapy in cancer. And then we have had people from like OSF Innovation talk to us about partnerships and how they work with startups in the area and how they work in Chicago and how do they bring these new startups on board and partner with them. And so like these first, and you also have these online modules that you mentioned that really you do things on your own pace. You learn about community health, you learn about population health, you learn about innovation on your own time at your own pace. And there's a few different options you can choose from, and whatever interests you the most, whatever things that you might not have heard about before, you can use that and bring that together. And all of that sort of comes together at the end of your second year. When you start your third year, you have 4 weeks where you do the simulation course, and you learn about innovation. You sort of do during your second part of your 4-week curriculum in your third year, when you're in the Osteo Rotation, you're given a problem statement, and you're given sort of, you're supposed to go ahead and identify the problem, define the problem, and then present a problem. But you use all of the stuff that you built into your first phase, or the phase 1 of your curriculum, using the methodology that really helps give you the building blocks that you can use to do a really good job of coming up with a problem, to learn how do I actually come up with a problem, how do I define a problem. And then you throughout this whole process, you have amazing people that you work with. So Dr. Ramirez is a great resource. Nicole, you're a great resource. You have amazing people at Jump Simulation Center that you can talk with, and they give you expertise on how do I become a good innovator? How do I become good at health inequities? How do I become good at public service? And all of this combined together helps formulate your capstone project that you present at the end of your 4th year. Go from there. Sorry, that answered your question.
You did answer my question. Yes. Thank you, Saad. All right. That concludes our Erg Med portion. I believe we'll have some time at the end for any questions or answers.
Thank you, Nicole. Thank you, Saad. Yes, we'll have all of our questions answered at the very end. Keep putting them in the chat, and we'll have all of our panelists come back onto the stage to answer them. But we have one more program, and that is our Global Medicine program. So I'm going to turn it over now to Dr. Olamide Jarrett to give a presentation on Global Medicine.
Hello, everyone. Sorry, 1 second. I want to apologize in advance. I'm starting to have some internet issues. Hopefully, it was cutting in and out when I was listening to the other presentations. Hopefully, I have solved that, but I want to apologize in advance if we have any technical difficulties. So, my name is Dr. Olamide Jarrett. I'm the Associate Director of Academic Programs for the Gmed Program, the Global Medicine Program at UIC. And so when we're talking about global health, we're talking about the study, research, and practice of improving health and achieving equity in health for all people worldwide. We're discussing, emphasizing transnational health issues, determinants, and solutions, similar to what's been expressed before, and involving many disciplines within and beyond health services to promote interdisciplinary collaboration. And so the Gmed program is centered within the UIC Center for Global Health, which was established to improve health and reduce health disparities of populations and individuals around the world, again, using a collaborative transdisciplinary approach, and making sure that we're incorporating anti-colonialism, anti-racism, and equity in all of our efforts. And so what we care about in terms of Gmed values for our program is that it's important for our students to have a understanding concept of equity, collaboration and partnership, diversity, inclusion, and scholarship. And again, very important that it's done through an anti-racist and decolonization lens in all of these efforts. So kind of going through a little deeper discussion to the Gmed program. So just like all the other concentrations that you've heard about, it's a longitudinal 4-year curriculum to try to give you a breadth of understanding about global health. And to kind of contrast with what you've just heard about Erg Med, focusing on innovation, we're encouraging students to explore the much more broader depth of what is global health. So that it can include focusing your work in global health policy making, more traditional global health research in terms of having an aims and a hypothesis generating project, towards global health education, developing education and training programs around specific global health issues. So kind of very much a very wide gamut of what we consider global health, as well as global health practice. So it's a much more broader approach to global health than looking just at innovative technologies in the Erg Med program. Similar to the other concentrations, we use a combination of didactics, discussions, small group, as well as the simulations sessions. UIC campus has a sim center that was developed for teaching technical skills, but similar to some of the other programs, we're using our sim sessions to actually do simulations and issues like global health ethics. You know, when you're going to work with a global health partner, how do you communicate and understand what their needs are and making sure that you're addressing their needs. There are also extracurriculars that we do, such as book clubs. We're discussing books around global health, documentary viewings and discussions, where we watch movies around different issues related to global health topics. We also have the colloquial, which are skills focused workshops, where we cover things such as how to write an opinion piece in global health, which some of our students have done and gotten published. And then the ultimate focus of our program is a 4-year longitudinal global health project that's developed by the student and their capstone project mentor. And so I think kind of unlike some of the other concentrations that have spoken, the capstone project starts from your first year. So during your M1 year, you spend the first half of that year figuring out what are your global health interests and finding a global health capstone project mentor to help you develop a project. And by the end of your first year, you have a general topic that you want to be interested in, such as I want to study issues around obstetrics in Ghana. And you may not have a specific project lined up, but have a general concept that you want to work on. And you're going to present what you understand, what are the gaps and issues around that global health topic at the end of your M1 year. Then by your M2 year, you will actually flesh out the project in full if you haven't done so already by the end of your first year. And so at the end of your M2 year, you have sort of a poster presentation that you'll give, and where you talk about exactly what your project is, what are the specific aims and the goals, and what is your timeline to accomplishing that project. Most of our students actually get their capstone projects done sometime between their M1 and M2 year, because that's your kind of your last great summer vacation where you actually have an extended block of time in your curriculum. So a lot of them get that done during that year, but others get those projects done during their M2 or their M4 year. Oftentimes, capstone projects don't get a lot of work done during their M3 year because of all your clerkship rotations. So by the M3 year, again, a lot of the students have finished their projects and gotten the data for their projects, and so they write up that data and present that in. We want them to present that in a formal conference. So we want you to actually have an experience of what does it mean that when I do global health work, how do I then present that work to a larger audience so that it can be used? And so during your M3 year, you have to have written up an abstract poster to submit to a formal conference. It can be an international conference, it can be a national conference, it can be a local conference. UIC has, the College of Medicine has a conference that they hold every fall. And so some of our students present their work to that conference. And then finally, in your M4 years, the ultimate culmination, where you're presenting the final analysis of your capstone work as a final paper, as well as giving an oral presentation about the work that you do. And so a major part of this capstone process is really having strong mentorship. And so a really big part of our program is our mentoring program. So our students actually have 2 mentors during their program time. They have an academic mentor that's assigned to the students at the start of their first year. And that person will help guide you through the Gmed curriculum, provide advice and information about global health opportunities. And then, as I mentioned before, there's a capstone project mentor that the students select for themselves during their first year. And that person gives you a much more hands-on approach to mentoring, really guiding you through the steps of your capstone project. And you think, well, I have these 2 mentors that I'm talking to, and maybe they're giving me different advice. Well, to address that issue, twice a year, the students meet with both their academic and their capstone mentors at the same time. We believe in the power of groupthink, and 3 heads are better than 2, sometimes in working out problems and issues. And this is also important because things that have come up with our students is sometimes a student comes up with a project there and 1 year, again, let's say they're interested in obstetrics in Ghana, and then they do some more rotations and learn some more things during their general medicine practice and decide, actually, I really want to be an orthopedics, and I really want to learn about global health orthopedics. And so they go and they change their project, and as a result, also change their capstone project mentor, which is totally fine and allowable to do. But then when that happens, your academic mentor now serves as sort of a nice longitudinal continuity to know what you're working on, to know where you're trying to move towards, and help bridge those connections when you're having those discussions with your new capstone project mentor. Also, sometimes students are allowed to pick capstone project mentors that are outside of our Center for Global Health or outside of the University of Illinois. Some of our students actually already come in with relationships with global health partners from their undergraduate years, and they're totally allowed to have those projects and develop those mentors as long as you're going to have close mentorship throughout the process. And so again, having this academic mentor who understands exactly what's required of them for the different deliverables during their M1, M2, M3, and M4 years can help them help the capstone project mentor understand some of the limitations of what students can or cannot do is also very helpful. So that's a very much important part of the process. And so why choose the Global Medicine program? We believe that the graduates of the program will have a greater experience and understanding of the global health issues that face us in the 21st century, and we'll have careers as clinicians, educators, policymakers, or researchers. And so in terms of what our Gmed goals are, we're really geared towards preparing medical students for global health careers by providing them with educational experiences to understand the social, environmental, political, and economic issues that contribute to the world health disparities, help them develop skills in collaboration with partners to work with global health stakeholders to advance research, policy, and practice goals. Developing professionalism, working in global health, working with global health partners to respect the culture and adapting to practice in research limited settings. Developing skills in strategic analysis, program management, capacity strengthening, as well as research. And there's really having commitment to serving as practicing physicians with a focus on global health. Oftentimes, in terms of their capstone projects and what they do, obviously, being able to travel abroad for their projects is something a lot of our students look forward to. And we actually have funds that all global health students get to help support that work, as well as students also look for outside opportunities as well for other funding mechanisms. But also a big part of what we've been really pushing is not just being able to go globally to other countries, but what does global mean on a local level? So some of our students actually work with immigrant populations. So in terms of the work that we do, we focus on working with low and middle income countries or recent low and middle income or recent immigrants for low and middle income countries. So we've had students do projects locally, but working with recent Syrian immigrants. So recent Syrian refugees, or recent Mexican immigrants who just arrived within the US within the last year and are transitioning. So we have that work as well as students traveling abroad. And even in terms of students who've done work in other countries, we've stressed, especially in this COVID time when travel has been limited, is how do you build strong partnerships and have strong collaborations and really amazing projects when the student may not even travel to the foreign country and they're just working in close partnership with local partners on the ground in those countries who provide them with the information, and they're working together to really build really powerful projects. And so who is an ideal GMed candidate? We want students who are committed to working with global health communities and who are really passionate about addressing health disparities and inequities and have experience in working in multicultural settings. And so, a lot of times students feel like, well, I can't apply to GMed if I've never had any global health experience, if I've never actually traveled outside the United States. And that's not true. We're very happy to welcome students who may not have had the opportunity. There's definitely, sometimes a financial cost or just, life happens where students can have that experience. But we do want to know that you do have an interest in multiculturalism. So within your own community, if you've never, really gotten a chance to travel abroad, but, if there are different, ethnic, religious, different communities within your where you live? Have you had an experience where you've wanted to learn more about them, have sought to work with them in those communities? Those are also people who, but have also been interested to knowing what is like to work with those communities on a more global scale. Those are people who are also ideal candidates for the GMed program. So even if you haven't had experience traveling, you'll be a great candidate for our program in that sense. And so, and as you can see, our students love our GMed program as they traveled around the world and to show that love abroad. And so we would love if any of you would be willing to join and be part of that as well. And so now I'm going to actually have one of our students, Mohammed, talk about his experience within GMed and what that has been like for him.
Hello, everyone. My name is Mohammed. Why did I choose GMed? So a little bit about me. I come from a family of immigrants, and just seeing like the country we're from, there's a lot of health disparity, and I was just really motivated to help like make a difference, and I wanted to learn more on how to do that. And so I did a little bit of work in refugee camps in Jordan and Turkey, and I really wanted to grow upon that. And so GMed was the first steps to getting to that point. Being in GMed has just been like overall a great experience. And why do I specifically like it is that it creates this structured program for us to follow. Like from day one, you know what's expected, what lectures are available. And what's really nice is that like these are actually all necessary lectures for not just a global health perspective, but even like, in your future residency or local hospital that you're going to work in. And the things that like we cover, like IRBs or need-based assessment, these are applicable to anywhere. And frankly, if you're going to do research in global health or not global health, you need to know how to do an IRB. And these little tidbits are very helpful. In addition, it's like a small family. It's actually really nice. It's about 12 students a class, and you basically grow up together and spend a lot of time together, and you might even end up doing the same capstone project together. So that's another addition. So for example, my capstone project was assessing this social well-being and psychological aspect of Syrian adolescents in Istanbul. And I had a classmate with me in Istanbul for a month and a half. And that was a great experience. And talking about meeting people as well, you're going to have all these mentors, these researchers. Like I had mentors in Turkey where I had to write my IRB from there, and they would give me advice about my research, and then I had my mentors here. And recently in GMed we developed this mentorship where you have your research mentor, which is your PI, and then your academic mentor. And it's really nice because it really holds you accountable to what you're expected to get done. And also just it's also there for like a mental health checkup or just academic checkup. It's just an overall, like, how are we doing and what we can do to improve you. It's not even like specifically focused on GMed in that aspect, just how can we make Muhammad or this student excel in our program and medical school. And that sort of brings me to like balancing GMed and medical school. So what's really nice is most of these lectures are like about an hour lecture, and they're always going to be during lunch. And there's always food. It's also really good food, which is always a nice bonus. And you get to see your friends too. You get to spend some time, and it's very insightful things. They're bringing people, speakers, and attending, sharing their amazing stories, and you might get inspired to work with these people or not. And other events included I can't think of the word, but like a social event with all the like potential research people you want to work with or attendings. So it's really nice. And if you ever are struggling with anything, GMed is very accommodating. You can always contact people, and they're actually very, very open to listening to our concerns and help change the program itself. But other things is there's a book club, which was really nice. You read a book, you go to a professor, have dinner there. We had a movie club and things like that. And overall, it's been a really fun experience. It is definitely something unique you get to actually talk about, during your interviews for residency. As someone that's applying soon, like not many people have such a distinctive project or experience to talk about, and I'm really excited about that. Other than that, that's all I have to say. If there's specific questions or things you'd like me to discuss.
No, so thank you, Mohammed. And so kind of to clarify some things he's mentioning. We initially called, we had two mentors. I said the academic mentor. And so we initially called the second mentor, the one who mentored you in the Capstone project, the research mentor.
Yeah.
But we found that with some of the students, people have a very specific idea about what they mean by research. And so now we have renamed it, kind of like rebranded it as the Capstone Project Mentor to let students know that your project doesn't need to be like a traditional research project. It could be a health policy project. It could be a training and teaching program. And the students have done that wide breadth before, but oftentimes when they first come in as M1s, they're like, I need to develop a research project. Like, no, if you want to, that's fine. But there are lots of other things that global health is beyond a traditional, like a global health research project. So we've kind of rebranded. So that's kind of just to clarify that. And also, in terms of helping students find projects, as he was mentioning, we kind of do sort of a rapid speed networking events. Yes. Sometimes we have a slip to say speed dating, like no, it's not dating, this is a speed networking event where students get to meet multiple faculty members to see what projects they're working on and to get a sense of are those projects that they would like to take part in. Sorry, no.
I was wanting to say, like, we have those two mentors, but obviously, like, I ended up not going to I'm going to a specialty completely different than psychiatry. And I have other mentors in that area. And like, you're going to have so many mentors and they're so important just to get little bits of advice. So you're not like, you're not exclusively focused on these people. I actually talk to other Gmed people in the program itself.
Yeah, and we are very much about, as he said, supporting the students and making sure they're very supported through the whole process. Again, if you're running into problems, we're there to support. We're there to celebrate because our students do amazing things and they've published papers and presented at conferences, and they've done really great things in our program, have gone on to great things. And so I think I will end there, and I guess we can go from there to the Q&A.
Thank you so much, Mahanad and Dr. Jarrett. I'm going to invite all of our panelists and our students to unmute their videos and come back onto our virtual stage as we jump into our Q&A session. So as many of you were already practicing, we have the Q&A function at the bottom of the screen that you've been submitting your questions to, and we're going to read a few of them live. Please use the Q&A section at the bottom and not the chat, just so we can keep track of what we've answered and what we still have to go. But we did initially have a lot of questions about application, admissions, and things like that. So Dr. Miri, I'll turn it over to you to address some of those right off the bat.
Thank you so much, Bridget. I am so inspired after hearing the presentations and the work that our students are doing. Thank you for being here with us tonight. I'm not going to read your questions directly. I'll just give a few responses to some of the questions that I feel we didn't have an opportunity to address in the presentations that you heard tonight. So there were questions about the number of participants in each of the programs, and we don't have the same number of students that can join. So for example, the Rmed program can take in 28 students every year onto the Rockford campus specifically. And then we have the UMed program, which takes 18. We have about 12 students that we can bring into the Gmed program. And I think we heard for Erg Med that it was about 16 students. IMed can bring in 12 students. So each program has a different number of spots that they are able to accommodate based on faculty availability, because it is really intense one-on-one mentoring that you get, as you've heard from our presenters tonight. There was also a question about the process. When should you submit? I would encourage you to submit your Scholarly Concentration Program application as soon as you're ready to. Don't necessarily wait until the deadline of March 1st, because some of our programs do have rolling screening, rolling interviewing, and rolling acceptances. So as soon as you feel you're ready, you can go ahead and submit it. Again, as part of your supplemental there's a question that asks, are you interested in applying into any of our scholarly concentration programs? Once you check the box, a new tab opens, and then the questions are there. There is one submit button for all of them. So if you're applying to multiple and you hit submit once, the button will still remain green for you to be able to fill out the other one. So the application doesn't really close out until our deadline of March 1st. So treat it like a Google Doc. As you type information in, it is immediately accessible to us. And we did mention that there is an additional interview process for the scholarly concentration programs. And again, it'll vary for program to program. So Rmed has a couple days of interviews, intense interviews. The IMed interviews in partnership with the admissions office. The Erg Med program, as you learned, interviews post-matriculation, and our other programs interview along the way, sometime after March 1st, but definitely before April 30th, which is our deadline for at least planning to enroll with the institution. And then there was a question about, is it possible to be in the scholarly concentration program and the other programs? So the answer is yes. However, it has to be a scholarly concentration program that's available on the same campus. So the question of specific was for Erg Med and MD PhD. And Erg Med at this time is only available on the Peoria campus, and MD PhD is on Chicago. So it would be difficult, as you heard, to complete the program. But an MD PhD is a 8-year-long process, and so who knows? There's innovation in all of these programs, so it may still be a possibility. Okay, Bridget, those were all the admissions-related types of questions that I could address. I'll hand it back to you.
And I'll drop our link here. If you forgot what campus our programs are on, I'm just dropping our link to the curriculum for you to check out. For those of you jumping off, I will ask our panelists if they're comfortable to drop either their personal or their office's generic email address, just in case they have follow-up questions and they can't stay until the session ends at 5:30. All right, so let's turn officially to all the questions you submitted. And I'll just do round robin based on who I can see on my screen here. So this first question we have is for the Rmed program. So while there is a lot of interprofessional interaction, are all of your actual preceptors MDs, or are you ever precepted by non-physician providers?
Is that for, wait, which college is
This
that
one
for
is
again?
for Rmed.
Okay.
Okay, I have a couple students with me, so I will let Kelly answer that question. Kelly missed our earlier opportunity to speak, so thank you, Kelly, for joining us. If you wouldn't mind addressing that.
Yeah, so for clerkships and any other rotations that we are on, all of the preceptors that we follow are MD or DOs. However, there are some opportunities in our first and second year where we go out and are expected to follow a couple other interprofessionals. So we have one where we are able to follow a pharmacist. And then there's one other, we kind of didn't get to do it because of COVID, but I can't recall what the other experience was supposed to be. Lincoln or Dr. Fess might be able to tell you. We didn't get to do it because of COVID, unfortunately, but.
Right, there's supposed to be 2 different opportunities to shadow. One is with a pharmacist or a nurse practitioner student, or a nurse practitioner, and then the other opportunities are to work with some dietitians and social workers.
Great, thank you. Our next question is for Erg Med. So anyone here who's on our Erg Med squad, what type of innovations have come out of this program?
So I can take that. I think, a variety of them are still in the process. As many of you know, from the innovation standpoint, the road to becoming an actual product that potentially in healthcare is FDA approved, et cetera, and marketed is quite a long one. Fortunately at UIC, we have a lot of different commercialization roadmaps and opportunities for partnership. But just examples of things that students have worked on. We have a partnership with the Innovation Center in Uganda. And so we've worked with several problem statements that's come from the community there. Most of those have been applications that we built for like community health workers or village health workers to help them do their work more efficiently in rural areas. And get sort of the EMR into the hands to be able to do things around reproductive health, around diagnosis of depression and referral. I would say for some of our rural projects here, we've worked with schools around predictive analytics that we can refer students around anxiety, depression, and avoidance of both suicide and different, other sort of downstream effects like alcohol use and drug use. All the way to right now in development at the Innovation Center in Chicago, because we've pipelined it there to kind of be attached to DPI, is a card game that we use with our community care organizations, so our social care organizations, to screen for social determinants of health in a conversation, which then the community care worker can snapshot and allow it to be digitized and then help us to tabulate and understand the prevalence of certain social determinants in a population, then allowing us to act more relevant to local community needs. So lots of different types of things depending on community needs, all at different stages in development. But once we, our kind of clinical teams and our community teams get those ideas through, then we resource appropriately with different resources throughout UIC, from computer science to engineering, et cetera, to kind of get those innovations off the ground.
Great, wonderful. Our next question is for Gmed. So what are some of the countries that have partnerships with the Gmed program?
So we have partnerships with India. We have faculty who have a lot of partnerships in India, Ghana. I've been working trying to develop a partnership with Sierra Leone. So we have Dr. Vandeli has partnerships in there's so many countries now. He's got multiple countries, I believe. One of his is, I believe, Bangladesh. So we have, not except for Antarctica, but we have faculty of global partners pretty much in all the major continents. So if students are interested in working in South America, the faculty who have projects there, in Africa, in Europe, in Asia. Actually, I don't think anyone has any global partnerships in Australia and New Zealand. So we don't have anything there. But we have a very wide breadth of partnerships, and students are also allowed to bring in their own. So sometimes students already have, again, as I mentioned before, collaborations from their medical, their undergraduate years with an NGO that they volunteered with, and they come in, they want to continue that work on their project, and they're allowed to do so.
If I may quickly add that, my own mentor has 12 different countries he works in, from Bosnia to Kazakhstan to Tajikistan, India. It was so, even if I couldn't find, he would connect me with one of his colleagues across the country or the world. And one of my own colleagues, classmates, was he ended up doing Egypt, and there was no mentor from UIC in Egypt, and he just got connected through UIC faculty to someone at in Egypt and did his project there.
Great. Our next one is for Rmed. What do you view as the greatest needs in rural medicine?
Well, that's a very good question. I think that there's a lot of needs in rural medicine. The greatest is hard to say, but at this point, there is a great need for physicians in rural areas. I think that that's why we do what we do. We recognize that need and we can make an impact. There are other health profession shortages all around. Right now, in particular, there's nursing shortages, there's hospital bed shortages, there's other needs socially. But I think as far as meeting the immediate needs, we need to keep the supply of physicians up in rural communities.
And this question that someone submitted is a little general, but I'll throw it to Erg Med. How does UICOM support students interested in rural and global medicine?
It is a little bit general, but I think the program very much supports the development. When we created the program, we took about a year to do a needs assessment, and we looked at all undergraduate and graduate programs that taught global health, rural health, that had sort of fellowships in that space, as well as interviewing several folks from different residency programs, so we could make sure that what we were creating was unique, but then pulled from the best throughout the country. And one of the deficits, I would say, that a lot of medical students talked about, and folks that I had mentored through the years when I was at Hopkins, I think had noted, was that they, when they went on global rotations, if they hadn't pursued those before, they didn't really have a local mentor. Nobody traveled with them. They didn't have specific learning objectives or a way to debrief. And so even if they had had some of the structured learning experience at their institution, it didn't really integrate well with those experiences. So what we really tried to do was to concentrate on formulating a couple key partners that throughout the world that we vet through multiple site visits, looking at their clinical environment, their innovation capacity, their focus on disparities, and the mutual interest. And then we co-teach everything together. So partners from our innovation centers globally will teach our med colloquia with us. We'll vet all of those innovations, whether they're done in our rural space or their rural space. And so in that way, it's really co-taught, and we believe in the concepts of sustainable partnerships. And so we really invest in sort of the long-term build of global faculty so that we all together are supporting you. And then when we do that first global or rural austere experience, the faculty travel with you, and we have a defined curriculum, and we do debriefs every night, et cetera. So we're teaching on the ground with our partners in the country, and then come back and integrate that into your capstone. So we really try to make it sort of a hands-on mentored experience throughout those 4 years, with the idea that then when you go into residency, several of our med students have gone into residencies that have global health tracks now. As they move forward to create new projects and things in the future, they have really a baseline of how to do it. And so what the ins and the outs of that work is, they have that structure already down pat, because they've really done it in a mentored way the first go around.
Our next question is for the Gmed program. So how does the Gmed program ensure its global activities are ethical and have long-lasting impacts?
So that is actually something that's very important to us and part of our curriculum. And in terms of the training that the students get, in terms of didactics, learning about global health ethics, and also for our faculty as well, that's something that kind of a continuing education that we do. We really focus on a very much a collaborative approach. And again, as I mentioned in the presentation, focusing around that, we are thinking about and addressing issues around racism, otherism, and colonialism in our approaches. And so things like making sure that the projects that we do are the projects that the community wants. So we're not allowing students just to say, well, this is a project I want to do, just because it came in their head without any information and communication with our global partners. So that if a student's developing a project is in collaboration with them, is this something the global partner needs and wants? Because if they don't want it, they don't need it, then it's not of a benefit to them, then that's not a project that needs to move forward. So we do vet the projects that the students want to do before they move forward. And that's done primarily initially with the research mentor, but again, when they're part of what they need to do is also hand into myself and Dr. Chamberlain twice a year, kind of a report about what is going on and where they are in their projects, and we also use that as the vetting process to see exactly what their project is doing and how they're working through that piece. In addition to that, again, the didactics, where we're stressing those issues of thinking about, and in fact, and this is kind of speaking to something that Mahan brought to us in terms of how student feedback informs in how we changing our program. Because while issues of decolonizing and anti-racism were always part of what we wanted to do, it wasn't previously formalized into how the students did their capstone projects. And so now as the students are working on their projects, for each step along the way, their M1, M2, M3, and the M4 deliverables, they need to reflect on what are those issues on the ground around around having a decolonized approach in terms of having a collaborative approach. Are we looking at indigenous solutions to problems? Are we addressing issues of social injustice and social inequity for marginalized groups within a community? Because, you know, even just like, you know, here in the United States, in every single country, there's always a group that's marginalized compared to the rest of the group. And are we really looking at that and addressing those issues? And they need to really reflect on that in their, on a global scale, on a local scale, and also on an individual scale in terms of how they're working in their relationship. So that's something that we're stressing and making sure the students focus on throughout their time in the Gmed program.
This question, I see we have a lot of students on our call, and this question comes up so often, and it's, how do you balance the MD curriculum with one of these scholarly concentrations? And anyone can start.
I think maybe one of our students would be best to answer that question.
I'd love to answer it, because look, if you're passionate about something, it's honestly not that much work at all. If anything, it's exciting. And as someone that's been in the GMed, it was always nice to meet up with fellow students, because, you know, when you're going to lectures, everyone's just busy and focused, and this is our time to relax. And we always had really nice discussions. And as I added, it was like lunch. So it really wasn't overwhelming. And your first summer during med school is just open, and you can do so much of it. I personally, I think I finished like 80% of my project in that one summer, and I did not feel overwhelmed. And again, at least for GMed, there was times when something came the day before an exam, or something was just, you know, not the best time for us to meet, and we just vocalized that, and they were always ready to listen and change just enough, very easily.
Yeah, and for like the Rmed program, like during your first 2 years where you're doing a lot of the book work and a lot of the preclinical phase, for the most part, you're looking at like 3 hours a month in terms of what you're actually spending in class period for like our Rmed sessions, where you're getting exposure to these rural topics. But then once you transition into your third and fourth year, these different exposures that you're getting, they are part of the clerkship experience. So kind of like I mentioned, for surgery, it's an 8-week clerkship, where other members in my class, they spent all 8 weeks in Rockford. I did 5 in Rockford, and I did 3 in Sterling, Illinois. And same thing with like the family med rotation. The ones who are part of the general curriculum, they spend their 6 weeks all in Rockford, and then I'll do like my 6 weeks down in Southern Illinois. So it's not any extra work from that point of view.
And speaking from an Erg Med perspective, along the same lines, a lot of the stuff that we do our first 2 years is built into the curriculum. So we have medical colloquia that every med student has to do during phase 1. We have some that are specific to Erg Med, so that eases some of the burden that you have. And then the online modules you can do on your own time, at your own pace. So it really don't take that long. And it's something that you're interested in, and it's really informative. You learn these things that you really haven't thought of before. And for me, it was very engaging, something that I really wanted to do. So it was very motivational. During your third and fourth year of med school, you're doing sort of the Osteo Rotations piece. There's a 4-week elective that's built into your curriculum. So it's not like time off that you take that's part of your core electives, or that's part of your sort of electives that you take elsewhere. It's sort of built into your third year curriculum that you're going to be having 2 weeks in the 2-week simulation course and the 2 weeks in Uganda or Street or wherever it is. So it's not like extra time that you're taking off. You're not doing this on top of your clerkships or anything along those lines. It's 4 weeks. It's really the 2 weeks, the simulation course is a really nice break from day to day, like being in the clinic, you get to sit down and talk about stuff that you enjoy, talk about innovation, talk about global health, and then you can apply that right after during your Osteo Rotation, whether it's in locally or in a global setting. It's not really overwhelming at all. And then during your fourth year, you have a lot more time to like sort of continue working on your Capstone project and come up with and tie all your pieces together. So it's not really overwhelming at all, I think. And then in your first 2 years, you have a lot more time than anything, so you can really dedicate your time to sort of building the base and the groundwork to build on your third and fourth year.
And Kelly, I'm not sure if you had anything more to add.
No, so I'm also with Lincoln in the Rmed program, so the curriculum's the same. I would just add that really it's maybe a little bit extra work, but it's really not overwhelming, like everyone has already said, for any of these programs. And the reputation of these 3 programs is amazing. All of residencies always speak about all of the programs and how much you stand out as a candidate because of these programs, and the experiences you get is just amazing. So I just wanted to add that in there, that it is definitely worth these programs if you have to go do a little bit extra work. And like everyone said, it's really not that much extra work, especially if you really enjoy the topics.
We do get that question a lot. How does this help me get into residency? So thank you for bringing that up. And this can be for anyone here on the panel. We get a lot of questions, especially the questions that were submitted at the time of registration for the webinar about specifics. So if you can share 1 or maybe 2 specific experiences, projects that the students in these programs participate in. So we can get something tangible. Yeah, Mahana.
Do you want?
Yeah, sure. Like my capstone project's on the psychosocial health of Syrian refugee adolescents that have resettled in Istanbul. A friend of mine was doing emergency medicine in Cairo, Egypt. Another friend was doing women's health. Like actually, there's plenty. Actually, a couple of women's health like across the world. Like one was in India, and was in one of the Caribbean islands, and it's so variable. It's actually amazing. Yeah.
I mean, other projects that they've done in Gmed is a student worked with one of our hematologists who's working to set up stem cell therapy for hematologic malignancies in different LMICs. And so their students have worked with him to try to help set those up in different countries. We've had one of our faculty members is kind of like a big expert in disaster preparedness training. So their students have helped develop some of the disaster preparedness training curriculum and actually administer it in Caribbean countries. Or then other students have then picked that up and then did sort of an implementation and evaluation to see how effective that training was when the next disaster came up, which I know unfortunately has happened in Haiti. Those are just. And then there are other students have done like more basic science research where they're looking to see, I'm trying to decide now, I'm blanking when you have to say it now, of course you blank on it. But yeah, one student who was doing some work with around Ebola research, like looking specifically at some specimens with the NIH and doing that project one summer. So it runs the wide gamut of things that students have looked at in our program. And I'm just going to say really quickly that I now actually need to sign off. So I left my contact information if anyone has questions. Thank you.
Thank you so much, Dr. Jared. We know we're over time. If you still have a few more questions, feel free to hang on here, just a few more to get through. And Kelly, you were about to add something about the Rmed Projects.
Yeah, so I didn't know if you wanted just like a blanket statement for the rural medicine program. In your fourth year, you create what's called a COPC project. I am in my third year, so I haven't obviously started that. But when you are in your fourth year, you do a 16-week preceptorship, which just means like rotation or clerkship. There's tons of names for it. But you'll go to whatever site that you choose. It's kind of like you have to decide within classmates. but you go to a site, usually it's closer to your hometown if that's what you prefer. So you'll spend 16 weeks there on a family medicine rotation. And then within that community, you find a need for what you want to do a research project on. So that's kind of what the COPC project consists of. And Dr. Professor Lincoln can add on to that, but that's the main project that we do in our 4th year.
And the topics, to build on that, Kelly, the topics have included anything from assessing childhood obesity in the community and how to make an impact to improve that. So a lot of the students will choose to work with a local school and make an intervention for that. Sometimes it has to do with like nicotine use, vaping or smoking among teens, and interventions with the school system. Again, it could be regarding opiate use disorder. There's been some topics around that intervention, elderly isolation, getting elderly involved with activities. Of course, you know, with this COVID, it's been a little bit more challenging to make some of these impacts. There's been a lot of restrictions with going into nursing homes. So even though there may be a need with elderly communities in these small towns, there's been some limits over the past year and a half in what we can do. So a lot of the interventions have been kind of restricted, though there's definitely been the need and assessments done, but the lasting impact, you know, is yet to come as a result of some of the research. But there's a lot of opportunities, and a lot of the projects are determined based on the community needs assessment or the area I plan, which is done through the public health department.
I would echo that, Dr. Fess, and Dr. Jarrett mentioned it earlier too. When it comes to Erg Med, there's a lot of prep work done beforehand with our community partners to really identify the problem statements that students will be assigned, so that we do make sure that this is a community need. We are not coming in with ideas already formulated as to what we want to work on. We ask, what are the problems? We work to identify what those are and how we might incorporate. So it is very community driven. The innovation approach is very human-centered design approach. So we're really working with very closely to formulate all of the plans and what those rotations look like with our community partners to make sure that they're specific to what the needs are in the community.
And this question is both for Gmed and Erg Med. You mentioned all of the places in the world that you venture to, whether it's Egypt or India or the Caribbean. Are there language courses to practice a different language, you know, Spanish medicine, French medicine, that's more than just survival language skills? Or should you already have those languages in your wheelhouse before going?
So that's actually a really interesting question. I was on a panel for Gmed for the new M1s recently, and someone asked me that. You know, the answer is no, you do not need a known language. And if there was a tool that I would use, I personally use Duolingo to help me with the Turkish language when I was there. But thankfully, I've been to Turkey plenty of times to actually learn a little bit. But as someone that speaks Arabic fluently, that's been studying for at least like 12 years, it was very appropriate and helpful in doing my research, because I was interviewing in Arabic and I have to translate these, and a lot of things they say you have to know a little bit of a cultural background as well. So I actually told the Gmed students working in, because a lot of them come from immigrant backgrounds, like working in your own immigrant background helps. And it's interesting, like we had a student from Ukraine working in Ukrainian patients, a student from India working in Indian patients and such. But my friend that was with me is Serbian background, but he was, you know, working with Syrian refugees. And though I will say I helped him a little bit here and there, but he had a translator, so we took care of that. So no need exactly.
I would echo that response too, Mohamed. There's no specific requirement. When we were in Uganda, we did a lot of our team that we worked with at the Innovation Center. They actually had prearranged to have translators. So when students went out and did the interviews, they had already we had prearranged that before we arrived, to make sure that we did have the communication networks all set up and the communication channels were open before we got there.
All right, in the couple minutes we have left, let's end with this question for Gmed. And Mohana, thank you for being the representative for this. Does Gmed involve specific clinical exposure tailored to global medicine? And how may this tie into perhaps residencies in global medicine or other specialties?
Sure. I was actually typing that up, bro.
Oh, okay. Yes, feel free to respond to what you what we may not have covered.
FYI to anyone that messaged the Gmed, I actually hit up all the Gmed questions. There isn't anything specifically Gmed has like a specific like global health rotation, but I will say we have the simulation center that we use, which was really interesting. Like we had like ethical situations in like Uganda or like Caribbean. It was just a really, really nice experience. Other than that, a lot of our program is young, so I can't really see for that far in the future, but a lot of our classmates have been in fellowships in global health. I think last year we had someone do a Fulbright, and even someone in my class is doing a Fulbright scholarship. And a lot of us are super passionate about global health, maybe locally or globally. And I like to believe that a lot of us are going to still do globally. I definitely will. I actually cannot wait, but it's still it's a long way to go.
Wonderful. Well, thank you all so much for attending tonight's Scholarly Concentration Part 2. I'll go ahead and drop our link to our previous Scholarly Concentration Program. This is the same channel where this recording will be uploaded sometime either by Friday or Monday at the latest. If you didn't get your questions answered, go ahead, check the chat and email the program directly. I'll also drop our general email. That's for Dr. Mary and I from the admissions department, talking to all of our prospective students who are out there applying right now. You can email us directly and we'll make sure that we get your question to the program that can answer it best. So thank you again to our panelists and to our audience for joining us tonight. We had well over 100 people, so that was way beyond our expectations. So we look forward to seeing all of your applications in the future to our programs. Have a good night, everyone.